Cancer registries have been around for a very long time. In England, they've been around for 50, 60 years, and they were initially set up to monitor the safety of the population for radon exposure. But what they actually are is the most phenomenal resource of cancer data collection. And over the last 10, 12 years, I've run a modernisation programme for the cancer registries in England, so that we now have, rather than just a cancer registry, a cancer registration service, which collects data on every patient in the population, nearly 500,000 cancers a year across the population of England. And it's no longer just a thin data set of a few data items, but what we're looking at is the treatment, the outcome, the risk factors for every cancer patient in the country. It's quite a lot of data. I mean, it depends how you count your data. I mean, it's not large by terabytes size. I mean, if you want to collect X-ray images, which we don't collect, you can have a lot of data. But it is a lot of data items, and it's also a lot of complex data. So, we have up to, well, probably over 1,000 data items on every tumour. So we're interested in tumours rather than just cancer patients, because obviously over their lifetime, a patient may have more than one tumour. So what we do is we work at the level of a tumour, and we then understand the treatment associated with that tumour. But once you've got all of the details about the patient themselves, their treatment, their chemotherapy, their radiotherapy, their medical history, you're looking at 1,000 data items on each tumour. Cancer registries are not a research project. What they are is a national resource for protecting the public's health, and a resource for improving healthcare and healthcare outcome. And I think they've come into their own in the last 5, 6 years as we move towards personalised medicine. There is a certain irony in that personalised medicine is obviously about an individual, and here am I collecting data on a whole population. The challenge is that for a whole population, in order to understand each individual cancer, you now need to know about every cancer, because cancer is becoming a rare disease for individual people, and that's what personalised medicine is about. So when I see a woman in clinic with a breast cancer, I need to understand how that woman's breast cancer is similar perhaps to the dozen or so other women in the population who might have a similar cancer. And that's why you need this very, very large population data set. We focused on the data we know, as it were, what your diagnosis is, what your treatment is. The challenge is obviously outcome. And traditionally, we've used a rather crude measure of outcome, which is just survival. But actually, what we want to be able to know is what is the quality of life between this diagnosis and death? What's your mean disease-free survival? How long before you relapse? What are the complications? We're beginning to get data to fill that in. Once we have that on the actual population, we can then use machine learning algorithms to take the patient who's sitting in clinic, and rather than just saying, you've got this type of cancer at this stage, we expect you to live this long, here is a profile of what we think your life will look like over the next 5, 10, 15, maybe even 20 years, based on patients like you and the information we've collected over time. The challenge is around the issues of confidentiality, patient consent. There is a very significant and appropriate privacy lobby that patients need to be confident that their data is not going to be abused, that their confidentiality is not going to be breached, and that is my responsibility. As a doctor, my absolute responsibility is to protect a patient's confidentiality as if they were the same person sitting in front of me in clinic. And that duty applies to me and all my staff in the data that we collect. So we are very clear that we will not release anyone's data in a format that could identify them, unless there are very strict permissions for doing that. And one is their consent to do that. The other is if there is a legal gateway, so that we can be instructed as a legal method to release data. But in general, what we will do is we will release de-identified data, so that we're sure that someone's identity cannot be revealed from their data set. And that's the absolute responsibility. We also don't use it to make money. The government policy is we do not sell data for profit. When you have a new area of emerging treatment, one of the things you really want to have is good data to be able to understand the outcomes and interventions that you're doing. And so, I think what we discussed at the conference and the feedback is around how do you use the sort of data collection systems we've got to inform futures for proton therapy. To me, what I'm interested in is producing a resource that sits on the back wall of the clinic, so that the doctor somewhere in the world, sitting with the patient in front of them, is no longer relying on their previous medical knowledge and focal trials to say, our best guess is that we should treat you like this, although you don't really fit into the trial. It is actually on all of the evidence of every patient we've looked at across the population, using data that is most up to date. I can tell you that the best way to treat you now is like this, and the most likely outcomes are the following. And I think that is what I want to achieve.